Okay, I think we can begin. Welcome everyone again to this EHMA Conference 2019 and to our opening plenary session, Health Management Reloaded, Beyond Rhetoric and Myths. My name is Anu Partanen. Some of you have already met me. I was here in the morning, but perhaps there are some who have only arrived later. So I'll briefly introduce myself. So I will be moderating several discussions over the next couple of days. My background is in journalism, and in journalism I've written about healthcare systems in different countries, so I'm very excited to be here listening to the discussions and moderating some of them. I'll first go over a few just practical details, and then we have a few of our hosts who will come and welcome you. After that, we'll have the keynote speech and a panel discussion, and towards the end, we'll have time for your questions to the panel and the keynote speaker. First of all, some safety instructions. All the exits are marked in green and marked in exit signs. So if you should hear any announcements, please follow the directions and leave the building. I'm sure you know the drill. It's Finland, it's very safe. I'm sure, or I certainly hope so, that we don't have to care about all this. I also hope you have downloaded the app that will show you the conference program. It's very easy to do. I did it myself. You have to find an app called Huva app, and then you put in the EHMA 2019 code, and you can find the agenda, you can network. Some of the sessions require registration, so you can do that on the app. And if there's any news or changes to the programs, you can see those on the app as well. There's instructions in the program and so on how to do it if you haven't done it. I notice a lot of people have, so that's wonderful. There were photos posted and everything, so you should also download it so that you don't miss anything that everybody else is posting. First, I would like to introduce and invite to the stage Federico Lega, the president of EHMA and a professor of health management at the University of Milan. And Federico will say a few words to welcome you all.
Thank you, Anu. Good afternoon, everyone. On behalf of EHMA Board, EHMA Secretariat, everyone, welcome to the conference 2019. And we're very happy to be hosted here in Helsinki Espoo in this wonderful venue. Really comfortable, cozy, the right place where we can do really great things, great work. I have few information also to give you before we move into the plenary session. So I'm going to use some slides just to provide you this info. Let's see whether this works. Okay. First of all, the most important information is I want to thank you, our partners in this event, THL and the University Hospital of Helsinki. Thank you very much because they've been doing really a great job in organizing the conference. You can see again the venue, but all the organization, the place is fantastic, but also they give us a lot of support in really finalizing the program and give us a lot of support also in finding the right speakers and the topics that you're going to discuss during these 3 days. Second, I also want to stress the fact that EHMA has always been involved in supporting local communities wherever we went in conferences. This time, we did even more. As you can see, we have a specific association, SOS Children's Village in Finland, for which we're going to do also a charity run tomorrow and then on Wednesday. And we're very proud to be sponsor, a partner of this association with this conference. So I now invite Sonia, if you can come here for a second, just tell to the participants of the conference what it's about, so we can all join you in this great effort.
Thank you. Hello, everyone. My name is Sonia Hulkkonen, and I work with fundraising and sponsor relations with SOS Finland. We at the SOS Children's Villages Finland work to ensure that no child grows up alone. Every child has the right to belong to a family and grow with love, respect, and security. So there are SOS Children's Villages activities in 13 municipalities all around Finland. We provide basic care for children and strengthen and support for families that are at risk. SOS Children's Villages has been active in Finland since 1962, and we are also a member of SOS International, Children's Villages organization, which has operations in over 130 countries. So we'd like to encourage everyone to participate in the EHMA charity run and to donate for children that are most vulnerable in Finland. The suggested charity run participation fee is 20 euros, but of course everyone is welcome to make their own choice. You can sign up at the charity run either today and tomorrow at the registration desk, or also tomorrow during lunchtime at SOS Children's Villages booth, which is right downstairs. Thank you for your support for children, and enjoy. Thank you.
Thank you very much. We're very proud, as I said, to be partnered with you in this charity run, but also in all your activities. I also have to thank you and say that the conference was designed together with the students of the Aalto University, which is another important partnership we had in designing and providing the contents for the conference itself. So I would like to thank you, the students that participate in this rather say adventure all together with us. I also have to thank the Visit Espoo and the mayor of the Espoo city, which together with the city of Espoo are hosting us for the welcome cocktail tonight. As always, EHMA is, as I said, is all working together with the local communities, and this time we work with the city of Espoo, with the local community, with the mayor, and so it's going to be, again, a great example of how we can partner together and leave a legacy behind us. EHMA is not just coming here and be here for 3 days and that's it. We want actually to leave a message, and we want to also help the community to reflect on what they do in healthcare, in health management, in integrating community with the health system. And I think the fact that all of us will be there for the cocktail tonight and for the next 2 days discussing issues is also an opportunity to provide to the local community something to reflect on. And I have to say in this respect also a big thank you to the steering committee that actually provided us a lot of support in designing the conference. Then next, I have to introduce the fact that we are launching in EHMA a new special interest group, one on governance. As you can see here, I remind all of you that we have a number of special interest groups active in EHMA, one on integrated care, another one on primary care, one on best practice in healthcare management, one on health workforce, and one on health futures. And now we have this specific one on governance. I really want to thank you, the Good Governance Institute, to be active and promoting this new special interest group. I really push you, everyone that's interested, to join this group and start good conversation on governance in healthcare, which is a much needed improving governance, a much needed issue, or much needed themes on which we all should work. And finally, we also have our continued activity on Amazon. So we will have, during the closing plenary, say, awarding of the final discussion on the new Amazon project, or the new Amazon specific, say, competition. So please join us at the closing plenary in order to also congratulate with all the participants and have a fruitful conversation discussion on the specific topics of the EHMAthon 2019. As you can see, it's a very interesting topic. Ecological sustainable medications, how can we reduce the ecological impact of medicine? This connect with the overall themes of this conference, which is sustainability. It's an environmental sustainable conference, but it also has to do with all the different sustainable challenges that we have when we look at the health system. I guess that's it.
Thank you, Federico. Next, I would like to invite to our stage our Finnish hosts, Dr. Marina Erhola and Markku Mäkijärvi. Marina is the Deputy Director General of the National Institute for Health and Welfare here in Finland, and Markku is Chief Medical Officer of Helsinki and Uusimaa Hospital District HUS, which operates 22 hospitals and covers healthcare to 2.2 million people. If anybody was here in the morning, I said 1.6. Markku pointed out 2.2, so quite a sizable district. Please go ahead.
Good afternoon to everyone. Some of you were present here already this morning when we gave our welcome speeches, Markku Mäkijärvi and myself, so I think we are making them a bit shorter. But anyway, once again, to all of you, you're most welcome to Finland. I am actually very happy. I'm very happy to be here today. It's been a nice and long process of preparing for this conference, and it's nice to see the full lecture hall here today. Also, Finland, our country, the country I love to my heart, is showing its best today. We have nice weather, we have nice circumstances here, we have nice architecture, and most of all, we have all of you from all over the world here today. This is really great for Finland and great for the organizers, and I hope also you will then leave home saying that it was also great for you. Just a few words about the National Institute for Health and Welfare. We share our past with the European Health Management Association. We are an institute that studies and monitors the health and well-being of the Finnish populations. We gather lots and lots of information. We do studies, we do researches, we do reports. We work very closely with the government and also the regional healthcare providers. Our data is open, and we are making more and more sure that our data is not our data is data of everyone, which means that everyone can also use it. We are a long-standing member of the European Health Management Association. We have many years together. Our experts have been working in the board, in the scientific committee, and also in the Young Advisory Committee of EHMA. This is the second time the EHMA conference is in Finland. It was held here in Lahti, which is my city of origin actually, so I'm very proud it was in Lahti the last time, and now it is here in Dipoli. We Finns, we also have a lot to learn also from this conference. We have been struggling with our health sector reform during actually more or less 14 years now with 4 different governments, and I hope we finally finalize it during this new government. So when reforming healthcare systems, we need to know not only where we are going, but we also need to know where we are coming from. Only that way we understand what kind of a reform we need and what kind of a reform it is practical and possible to conduct in a country. So during this meeting, the theme is Health Management 2.0, which means that we, all of us together, we Finns together, we globally, everyone together, we are doing a reform, and we are actually managing to run this nice conference. This conference is an excellent opportunity to have discussions here in the meeting rooms and also in the corridors, and especially during the social events of this conference. And I hope that many new people meet each other, and that will be a fruitful cooperation for the years to come. So once again, on the behalf of National Institute of Health and Welfare Finland, I warmly greet you here in Dipoli today.
Good afternoon, everyone. Also, on behalf of the Helsinki University Hospital, warmly welcome to Finland and to Espoo Dipoli for this annual Congress of EHMA. We are honored and delighted to be sponsoring this event and also taking part into the organization. Maybe part of the good weather is also our influence, hopefully. I was born on Sunday, so maybe it's related to that. In the morning, I was shortly telling you the most burning points of the university hospitals' challenges in current healthcare management and in the future healthcare management. I called them problems, and after the session I got the comment that you were quite brutal. Well, they are problems. We should be glad, because then when we have problems, we can start solving the problems. I don't know what to do with the challenges. What do you do with the challenges?
Address.
Oh, you address them. Okay. It's, well, kind of shady. Well, anyway, problems. We all know this. You must have the same things in your countries and organizations concerning personnel, concerning knowledge, concerning fast development of medicine, which are one of the problems or maybe it's, this could be a challenge. Increasing demands of the patients. I'm not talking about consumerism, because that's also one thing, but kind of a rightful demands for good treatment and good diagnostics. High quality, excellent patient safety. I think they're justified demands from the patients. Rising costs, well, we'll talk about them, I'm sure, in a minute. Competition, and, well, management, leadership, and in a way, decision-making. It's very decisive, it's very important that an organization is able to decide fast enough, because things are changing, the environment is changing, and if it takes too long to make a decision from an organization or from a leader or a group of leaders, it's not good. They cannot do as much as they could if they would be faster. Well, from the university hospital point of view, the research funding, especially for clinical research, very tough nowadays. But anyways, we try to solve them, and I'm happy to have so many of you here today, tomorrow, and day after tomorrow, solving these, finding solutions for these problems together. Because I think these problems, these challenges are more or less global or even universal. And many solutions work in many places. Maybe you have to tune them a little bit, but the basic ideas, they work. I just, after the morning session, I went to the posters and discussed with a colleague from Rotterdam. And they are running a project solving problem. Title was something like acute care for elderly in rural areas. Well, that's my topic too, and probably some of yours. It's a common problem. And as far as I understood from the possible solutions, some of them could work even in Finland. So that's one of the reasons we are here now together here in EHMA and looking for good solutions for the burning problems which are common. So I think I've said what I wanted, so more of it in the panel. Thank you and welcome once again.
Sä istahdat alas. Okay, thank you, Marco and Marina. So now we will move on to the keynote speech, but I would like to also invite our panelists to come on stage so Marco doesn't have to sit here all alone. So Josep Figueras and Eva Turk, and I will do introductions for them a little bit more later once we get to that part. But now I would like to invite Federico back. We're making him work today, and he will give us a 15-minute keynote speech, and then we will have a panel discussion.
What is the watch?
I'll keep track of time.
This one. So again, welcome again, everyone. Try to be effective in presenting a few reflections about how the landscape and the contents of the job of healthcare managers is changing inside the new scenario, the new context of which all health systems are living. I'm going to use a few slides just to help myself. First of all, I want to share with all of you the fact that, from my viewpoint, we live in a new normality. Many health systems have gone through a major financial crisis, have been struggling even to survive to some extent in the last 10 years. Originally, we thought actually it's just a phase. It's gonna move away. We're gonna regain the previous state. It doesn't happen. It's not happening. We have a situation we're going to be very unhappy the way healthcare systems work because there are a number of trends, structural trends we cannot really, in any case, face to the rather say, full extent. We need to consider the fact that money is not going to be sufficient in any case. Okay? Further, access to innovation is going to be unequal. Even if we try as much as possible to make it equal, it's going to be unequal. People have different possibilities. The system works in different ways. Professionalism has never been as weak as it is today. Professional status has been devaluated a lot in many health systems, and so that's actually affecting the motivation and the way through which professional works. Consumerism seems unstoppable. Many health systems, even if they still profess to be NHS-based public, they very mixed, and people are shopping around. And the more they have opportunities, the more they do this. Obviously, the financial crisis has stopped some of the consumerism, but still it's certainly a trend there. Selective universalism is reshaping the notion itself of NHS. Even if the politicians will never say this openly, we already are in a stage of selective universalism. For the last 10 years, at least, we've been there. Okay, we have to make priorities. We have to select who is going to have what. And this actually is completely different from the rhetoric that we often have in systems. Performance, accountability, transparency, a number of context-related, let's say, dimensions being changed. So working in a health system as a manager, as a leader today, is completely different things that they're doing this 15 years ago, 20 years ago. It's a completely new normality. So many health managers working in what I usually define a much more hostile environment, okay? Where challenges are definitely multiplied. When I started to work in healthcare in the beginning of the 90s, health managers were happy to do health managers because everything things actually growing. It was a length of opportunities. Things actually were very interesting. Now many health managers are trying to struggle and say, oh, what is the job I'm doing? What I want to do yet or not is still a problem because many of them actually are feeling the burden of a completely different scenario and the complexity of this scenario. So how do we cope with a new normality? A number of new paradigms have emerged over the last 10 years because we've been trying to rewrite the way we cope with healthcare delivery. So a number of new opportunities, new thinking has emerged. We move from the notion of empowerment. For many years, empowering citizens was actually the major issue. And then we moved to co-creation, co-delivery. So we need to do much more than just empowerment. We need to make citizens responsible for their own health and to participate in the design and delivery of the health. We move from compliance to concordance. We used to have a problem. The problem is having the citizen or the patients compliant to their therapy. Now we move it to a next stage. So no, it's about concordance. It's about agreeing on what needs to be done and when it needs to be done and why. Then we move from disease management to population health management. So we say it's not about just taking care of a disease. It's about educating the population to be active in taking care of their healthcare, managing risk factors rather than disease. So we are challenging health system to do much more than they used to be in the past, from reactive to proactive and so on. From hospital to focus hospital. Now we're in general hospital doing everything, and then we say, now we start to organize in, focus hospital, introducing specific target ambulatories, centers, clinical service lines, whatever you want to call them. We started to change the way hospitals organize from the traditional specialty-based model to new ways, transversal, horizontal, metrics, and so on. From competition to co-petitions, public-private. We started to say, can we afford to have different actors in the same catchment arena and not having any relationship among them? No one actually steering behaviors, realigning strategic development, and so on. So we started to discuss how can we move to that directions. It's not easy. Nothing of this, what I'm saying, is easy. It's just happening, but it's happening slowly, and maybe we wanted to get it faster. That's why we need a new cohort of managers or leaders in this respect. From funding to performing, we used to pay service delivery, now we pay performance. Okay? At least we try to pay performance. Results, outcomes. Okay? That's reshaping the notion itself, how do we fund healthcare for the future. From service delivery to business modeling. When I started to work, the problem is, how do we deliver the service? Now it's what kind of business model we need in order to target those specific cohort of patients, that class of patients. How do we attract them? How do we make them actually interactive in the process? So business modeling has came to healthcare much more than used to be in the past. Even in the public sector, we're now talking about business modeling in healthcare, which is a complete revolution for most of the doctors and the professional. They never thought about reconceptualizing the way they deliver healthcare through the lenses of business modeling. From mass health to precision medicine, I don't think I need to add anything on this, but this is actually, again, it's a complete turn, 90 degrees turn in the way we expect healthcare will be delivered in the future. So health management is not anymore just an issue of effective or efficient delivery of services. It's much more. It's not about just being efficient or effective. It's about reconfigure, transforming the way healthcare is delivered. That's what we expect from health managers. Politicians will not do this. They will not do this. They have no interest in doing this, because sometimes when they start looking at these issues, they immediately see the consensus problem behind that. So that's why managers often are right there on the shop floor with physicians, with clinicians, with professionals, having to find right compromises to develop all this. It's very much about envisioning and executing the new paradigms. That's what we look for. At least this is actually what I would suggest we should look for when we look at how health management should develop over the next years. So if we have a new normality, and within the new normality, new paradigms emerging, what are the new protagonists that are coming out? We have, at least from my perspective, a number of key roles in search of authors, also in search of protagonism. At least I will mention these three areas in which a lot of investment, I think, is necessary. One is the medical directions. Okay? We appoint a chief executive officer, a general manager in the past, but now we've come to the point to understanding that having a medical director at the organizational level and having a strong medical direction is becoming fundamental, as well as investing in clinical top and middle managers, in engaging them. This is nothing new, but I will say something about what we've done in the past, what we should do probably in the future, and then invest in the technostructure and the staff, all the people supporting the management, the top management in performing. Why we need a strong medical direction? Because service reconfiguration doesn't happen by itself. It's not just led by professionals. Someone has to steer the professional. The professional needs to work with someone actually has the same language, understanding, and can even challenge the professional itself when it comes to how do we organize the specific service delivery? How do we rethink the business modeling? And then there's a lot of issues concerning introduction of innovation and the assessment. And again, you need to have a medical expertise to do this. That's why medical direction, strong medical direction, can be much more effective in finding the good ground to, develop a good conversation with professionals about when and how should be introduced a certain innovation or make a certain decision-making concerning priorities. Then we have the clinicians. We ask them to move beyond what is usually called the custodial strategy. So we ask them to step on and say, look, you're not just representing your collaborators or your unit or special departments. You, first of all, you're part of the top management. As if you're part of the top management, you have to steer the organization with the medical directors, with the chief executive officer, rather than proposing to them what are the issues, the problems. Okay, you need to actually step in a different direction, look at the organization from top down rather than from bottom up, which you usually do professional, because they look for consensus among their collaborators rather than consensus from the top managers, which is a completely different perspective compared to what usually happen in enterprises or in the rest of the world. We have new roles in bigger organizations, bigger and bigger. Whole health organization has been growing over the last 10, 15 years. So we need to adopt new models. We have new responsibilities, leading multidisciplinary teams, leading clinical service lines, leading centers, leading focused hospitals. So that's a new challenge, and we have not prepared our professionals to do this. And there's an acceleration in the task shifting and skill mix, which actually generates turf wars, a lot of, necessity to realign expectations from clinicians on one side and the other professional, health professional on the other side. This used to be in the background the last 10, 15 years, but now it's right top on the agenda because sustainability of health system also requires a major investment in this area. At least it looks like. Okay, there are good conditions. So we need probably really the leaders, just the people training budgeting or human resource management or whatever we've done in the past. We need to step up in a different directions. And then technostructure and staff. A lot of investment in operation management. We know that really makes a difference, having an operation manager helping the top managers to run the hospital and look at the hospital rather than any else organization from a different perspective, from the process-based view, basically. And the notion of patient flow logistics has been becoming central in the agenda of many health organizations. That's what we need to improve. We need really to improve that area. We need a completely new area in human resource management, which was basically neglected. It's about talent management. How do we develop talents quickly, move them forward? How do we recruit them? How do we attract talents in our organization? In the past, it was not a problem. You would expect if you have good names, good. But now try to attract the talent in a small hospital, in a rural area, in a difficult situation. They won't come anymore. They will come and cherry pick in the best places. And you're going to have class A and class B or whatever in a whole system. So everyone has to actually develop new ways of looking at how do we recruit professionals, but also how do we manage the next generation. We never actually worry about in many health systems whether the senior one would teach to the junior one, whether they will prepare in the next cohort of professional. It was left to the professional. Then we discovered that not always they do this. They don't always have any interest and incentives to pass the bar to the next generation. So we need new human resource managers, the technostructure staff, and then clinical competence and professional development. Again, in many systems, there's a big need to have a specific staff dedicated to help the health organization to map the clinical competence in the professional, build professional development path, so assuring that we have the right professional and the right place in the right time with the right services, which goes back to volume-based quality, to all the things actually you know better than me, that now are central to the agenda in many systems. So without an investment in these three key roles, I think it's going to be very difficult, the life of health managers, health leaders. And that's why we expect them actually to propose a specific focus on this kind of investments, creating the conditions, creating the enablers for the next step. So, I'm coming to the end of the presentation. We probably have a new posture that we ask to the health managers. They're leading they now are leading a very complex health organization in a complex environment, even hostile. So what do we expect from them? Well, first of all, they're very good in doing sense-making and providing specifically sense-making for the weak issues, waiting list, emergency care, networking, public-private. So those are weak issues. You don't have one single solution. You don't even have a solution sometimes. You just do experiments. Okay, let's try whether this actually will help us to improve the situation. But we're still struggling, because otherwise, after 30 years or 40 years, we will not be still talking of the same issues. When you look at complex social system like healthcare organizational system, whatever you do is usually is an experiment rather than just a fixed one best way solution. So that's why we need leaders to do sense making, explaining why we do this, and eventually how do we come out and move to the next experiment. They need to be very good in playmaking with multiple actors. They basically manage networks, okay? So that's something that doesn't need to be explained more, but again, some of the managers were really micromanagers doing a thing, okay, I need to make efficient my organization. This is not anymore enough. That is not what we ask them. The future is about creating stable relations with other health organizations and generating opportunities and strategic development in that context. Consistent and continuous engagement of clinical leaders. They need to develop a collective ambition for the clinicians, for the professionals. The health professionals, clinicians need to look at the leader and say, okay, I see, he or she has a project. There's a collective ambitions. We want to become these things. Now, it's easy if you have, but I'm going to challenge Marcus on this. If you have a university hospital, because the collective ambitions in a university hospital is already strong, much more difficult if you have a small rural hospital or other type of health organization. You need to build that. You need to, obviously, to manage through a method. It's about having a method. How do you manage the organization through a cycle, through a year? How do you engage them? What is the level of participation? How do you bring professionals on board on decision-making? How do you actually explain and do sense-making in the process? My personal experience is that many managers are good managers when it comes to the skills, but they have no method. They are not consistent in the way they manage the organization. They solve problems, they don't lead the organization, which is a different thing. Solving problems is not leading the organization. It's a completely different things when it comes to what really make a difference. And they need to work more in intrinsic and extrinsic motivations of clinical leaders. They need to have really, good reflections on what motivates the clinical leaders, how they can move whatever are the levers they have on generating more extrinsic motivation, and don't just rely on the intrinsic motivation that health professionals usually have because they love their job, because they have chosen that, because it's a mission, whatever. And finally, they have to use strategically any possibility they have in politicking and use the request for transparency and external scrutiny as an opportunity to put their organization under external supervision so they accelerate changes. They enforce changes because they use the external environment to promote changes internally, because otherwise they might be resisted by the physicians. Try to adopt a performance mechanism, performance evaluation system for the professional without having an external support. If you have an external support, that's actually is going to be more quicker and more effective. If you have to negotiate between you and your professional, it's going to be much more difficult and resisting. So I'm not saying this actually is going to change our world, but I wanted to put in discussion with the panelists the fact that moving a health organization from good to great requires probably new investment, at least in the areas that I just mentioned. And specifically, when I look at what I mean by health management reloaded, I have in mind two things. How should we train the professional? How should we select and reward them? That's a big question. I think we have a lot to discuss in this 3 days conference about this. This is something that I believe we need to do completely different from what we have done so far, or at least partially different. We need a less technical training, even less behavioral in the traditional sense. I think we need much more reflective practitioner activity. We need to help the health managers to reflect on what they've been doing so far, why they've been doing certain things, what as it works. So we need to create a new setting for training those people. I'm talking about the people already with experience. So if you're talking about the young generation, the new one, probably we need to develop different type of training. But certainly we need to make a reflection about what does it take to help current health managers to become the leaders we expect to become. And second, I think we need to also invest in specific research. We have acceptable research on what is the new normality. I can find lots of papers that describing the situation and putting out, even if not often comprehensive, but giving us a good framework about what's going on. I think there's poor research on new paradigms, a lot of confusions, a lot of rhetoric, and why we need to say, well, this is what we mean by a focused hospital, this is what we mean by population management in practice, this is what we need by concordance. So we need to do some research on this. There's a lot of interesting things for researcher and scholar. We have insufficient, completely insufficient, in my view, focus on the new protagonists and what actually we should provide to the health managers as evidence that those investments have a good payoff when it comes to managing, leading their organization. And we have completely non-existent research on what we mean in terms of or the development of the next cohort of health managers. What should we focus on? And that's it. Thank you very much for your attention.
Thank you, Federico. So we'll move to the panel discussion. I will just very briefly introduce our panelists. So we have Eva Turk, who's Associate Professor at the Science Center Southeastern University in Norway. We have Dr. Joseph Figueras, who's Director of the European Observatory on Health Systems and Policies. And then we have Markku Mäkijärvi, our own Finnish representative, who has it easy time at the University Hospital, if I understood correctly. So let's just start briefly. We're running a little bit behind, so we'll do brief comments and then we'll open the floor. Could I first ask Joseph, you work with health systems in different countries. What does this sound like to you? And do you think it's universal from country to country or health system to health system?
Yes, no doubt. Not only on health systems between countries, but also in many other professions. I could imagine that you call about public health 2.0, clinicians 2.0. So actually, when you work with your sister organizations, ASFER, UFA, and so on, some of the questions they're facing and some of the results, such as leadership and different skill mix, are very, very similar. But I think the part that is really interesting that I wanted to raise in this debate, building on the excellent presentation of Federico, is how this new 2.0 relates with the old, if you want, old new protagonists. So is this idea of the population perspective. managers need to come out of the autism of their institutions to look at public health, to look at the models of care. They are totally affected by that. You see, you'll remember the times in which many of you of my age may remember the purchaser-provider split markets, in which you remember these concepts of allocative and technical efficiency. Managers were not supposed to work and worry about allocative efficiency. They were supposed to worry about technical efficiency, to do their widgets at best price, as efficient as possible, at best quality. They were not supposed to worry about whether we're doing the right widgets, widgets. I'm not pronouncing that well. Anyway, the right operations. I wanted to be smart and it didn't come out well. So what kinds of products, they have to be part of it. What kinds of products they need to put on the table. What kinds of products we need. And then it's interesting as well, it's not just with the health systems, the models, and public health, but also with the politicians. Managers need to understand better the political economy of change. I remember a time, maybe some of you remember that, I was in a country whose name I will forget, in which a new minister was appointed, and you know what the first thing he did? It was a he. He sent an email to all the top managers of all the hospitals and said, as of today, you're fired. I'll consider whom am I appointing tomorrow. So I'm not saying that managers should be all aware and be at the hands of politicians, but also I'm not saying that managers need to be technocrats doing their work, their hospitals, their management. They need to be very much aware of the political constraints, the political pushes, the 5 years, the best of luck of ministers, have 5 years of life, often have much less, and be able to empathize and be part of that. So that's another set of actors that need to be involved. The third one, and I'm not answering your question, but I thought you wanted me to reflect, so I'll finish the reflections, and then I'll come back.
Yes.
It's the fault of Federico that brought that as you were talking. Actually, I changed my presentation as I heard to you. Then it's the citizens, the other old actors. There's a lot of rhetoric about citizens. But what are we doing in hospitals? Well, or in other centers. We have a complaint mechanism and a complaint mechanism. And sometimes we do a survey. How much our managers are now pushing to have digital mechanisms for citizens to co-participate in decision-making, and the data and the evidence and the tools are out there. So if we are really serious about empowering, we need to do that. If we're serious about empowering, how many of our managers of community services or hospitals bring civil society in their boards, being real representatives of the local citizens, so the hospital goes beyond, or the community service, their own center? And finally, I think the old relationship we talk so much about with the clinicians, it's a big challenge of the managers. I think the managers now, clinicians have a hard time. We had an interesting discussion, a very heated discussion about the role of the hospital just before coming here. And someone said clinicians have a hard time. Clinicians need to adopt very quickly new skill mix, new artificial intelligence, new ways of working, new guidelines, open hospitals. But managers need to understand that. And need to understand it's not only clinicians. They need to understand there are other professionals they need to ally themselves with. They need to steer clinicians as well to make reality, to co-produce with the citizens, with the patients. For many of our clinicians, it's not really straightforward to use a digital system and work with a patient to make co-decisions. So it's been a lot of rhetoric about citizens. How much these managers understand and put that in place? How many of our managers are using really this performance indicators, this transparency, this benchmarking for the benefit of the citizens? We know that many of these benchmarks are not being used by the citizens. How many of our managers make an effort to make those useful? Many of you are doing that, by the way. Many of you are addressing that. What I'm trying to say is that the role of the manager is as difficult as the clinician, because it needs to really come out of the institution and look at this, again, fresh, at the relationships with all new protagonists. Sorry I didn't answer your question, but I thought you wanted me to reflect.
Perfect. Eva wanted to comment, and she can comment from the point of view of research, I take it, and Marco can defend health managers in real life.
Yeah, well, for me, it's just what you were talking, we are all part of the system, right? And we all know the saying that kind of like we get the results, every system gets the, how is it? Every system is perfectly designed to get the results it gets. So what do we need to do to get better is really my question, in the sense that kind of like we are living still in the old systems, and we are talking a lot about kind of like how can we better work together, or what do clinicians need to understand, what do managers need to understand, how can we involve patients? But to be honest, I think for me, it's like I've been following this kind of like for the past 10 years at least, and we are not moving and fast enough. And putting a health management 2.0, for me, it's an upgrade. Yeah? We are not changing the system. So we are not starting from the basics, really, kind of like of what we need to do. And I work now quite a bit with the innovation processes with startups and so on. And I think there's a lot that we, as healthcare system thinkers, need to learn from the way the innovation process works. Everything is based on human-centered design. We speak about involving patients, but we are the patients. So for me, it's kind of like, how can we really get better into when we need to make the changes, to really, what you said, kind of like think about kind of like making these small shifts, if it is. Of course, we cannot use let's say, the innovation process with like fail fast, yeah, because anyhow, we've been failing fast for a long time in the healthcare business. But I think it's really kind of like think about the systems. We really need to get to involve different professions into it much better than we do today. We need to change when we speak about the digital transformation. Digital transformation, it's not only bringing really kind of like the new technologies and artificial intelligence and machine learning and whatever into the system. It's about creating a new mindset. And I think this is where we as healthcare professionals and people who do research or deal with healthcare systems need to get better. And last but not least, it is about the leadership. We are the people that care, or that at least should care. And we are the ones that kind of like the purpose-driven or the value-driven leadership should make most sense in. So in a sense, it's basically when you ask the question, how can we then create the new leaders or the new managers of healthcare of tomorrow? It's not only about the education. Usually it used to be education, you got your profession and then you work in your profession for the rest of your life, basically. Today, this doesn't happen. So what we need to teach the future leaders is basically how to be agile, how to be resilient, how to really kind of like foresee the changes, how to learn throughout the life. And I think it's also kind of like where we as academia, if I speak only now from this part, is like we need to get better into developing the soft skills of the people, because the theoretic part and so on comes, but this is kind of like with how can we create the mindsets of the people that we are really resilient and can work towards sustainable healthcare.
Markku, what do you think about this?
Well, thousands of things I could comment, but let's try to make some sense out of this. To me, I think Americans would say we need a 180, real turn. I think we still tend to think organizations and also healthcare organizations from top to down, top to bottom, and also the leadership from top to bottom. But actually, we should make a 180 and turn bottom up And from bottom up, I mean the patient is up here, okay? Then you have the healthcare professionals in front line working with the patients. And you should start of redesigning our care processes together with the patients. And when you have done that, then you come to the middle management, and they should be redesigning their services, because there are servants, they're serving the frontline workers, how they are empowering, enabling them to do their best work. And then you have the top management, which will, the new name will be bottom management. So they will be then supporting the whole system and also discussing and conversating and making sense with all the other stakeholders, also the owners, political decision makers, and the rest of the society to make this really work. So this would be kind of my conclusion from all of this. We need a revolution, not just an upgrade, like Eva said.
Okay, we need a revolution. Anybody, we could now have time, hopefully, for a couple of questions. We're running a little behind, but yes, we have microphones here somewhere. That somebody, yes, is going to bring over this one here in the front.
Thank you. Steve Brooks, University of Manchester. Federico, I enjoyed your presentation. You had at the top, good to great, Jim Collins's work. One question I've got for you and the panel is a key element of Jim Collins's work is the need to confront the brutal facts of the reality. How mature do you think healthcare leaders are to confront the challenges that we face today?
Yeah. You hear me? Yes. I do agree with you. We need to be definitely more serious about using brutal facts in healthcare, moving away from rhetoric and having managers engaging clinicians, professionals, all leaders in discussing brutal facts, how things are going. Be honest with the fact, as I said from the beginning, that no system will find a solution. There's no perfect solution. We're going to have an unhappy situation, and so the problem is how much unhappy we want to be and where we want to lead. And it's I do believe it's a collective responsibility between managers and clinicians to have a conversation on this and deciding together when we want to go. And if the managers and the clinicians can work together, they can be much more influential with the political environment and then starting to say, this is what we need to do, because on the shop floor, every day we're there and we are the one actually challenged by patients, by problems, not you. And so if that happens, then organization becomes stronger and then become, even if I understand that actually Joseph said, you need to do, you need to be empathetic and understanding. And the politicians have their own cycle, they have their own environment, but yet I think brutal facts could be a good starting point to generate the different dynamics between the managers, leaders, and the clinicians, and even the politicians itself.
Thank you. We could take one more question, and then we'll need to let you go. So
maybe I could comment,
yes.
Because that's the work I do every day. We have 3,000 doctors here in the University Hospital. So I would answer to your question that some are willing to change, but the most are not so willing, or then they don't realize the need of the change. And even in many top positions, we have so-called leading experts, not expert leaders. And that's the change, that's the turnover we have to be able to do. But I think it's not their fault, because if you look at their education, their training, they are trained as medical doctors, medical specialists, experts, and so on. But they are not trained as medical leaders. Where is that university in Europe for medical leaders? I don't know if there is any. There is no. So how you get the leader without not educating them? By chance. Well, by chance you get some, but not many.
Any questions more? Okay, I think it was a very definitive discussion. Did you ever want to say anything to that previous? No? Okay. Thank you, everyone, very much for your participation. And so